It's good to be back with all of you today for our fourth presentation of this semester. In this presentation, I'll briefly describe the current context for COVID-19 cases nationally and here at Georgetown, and then I'll focus our time on the issue of vaccines. In January, the United States first began seeing a decline in COVID-19 cases. In recent weeks, these downward trends have continued. The number of cases, hospitalizations, and deaths nationally continues to decline. This can be attributed to a variety of factors, including greater adherence to public health measures such as mask wearing. And this is cause for optimism, while at the same time we must maintain our strong commitment to public health measures. At Georgetown, we are still experiencing our most difficult period, with the number of COVID-19 cases continuing to stay at an elevated level for our main and medical campuses, and particularly among students living in the surrounding neighborhoods. As you will recall, we first saw a rise in cases in mid-January, just after our semester began. The number of cases continues to be high, especially when compared with the fall. While we have been able to resume some hybrid courses for our graduate students, our undergraduate courses will remain virtual through March 8th. On-campus spaces, such as the library, are restricted to on-campus students and graduate students. Like at other universities, this winter is proving to be especially challenging. We had predicted this period would be difficult, and we are now experiencing those challenges. I now wish to turn my reflections to focus on three elements related to vaccines. First, where do we stand on vaccine development and authorization? Second, the approach to vaccine distribution in the United States. And third, our Georgetown community. What is happening here in our region? I'll close with a few comments on new questions that are emerging. As I've described in previous presentations, vaccine development is organized into multiple stages. This chart shares a global picture of vaccine development and approval, and the number of vaccines at each stage. Once a vaccine demonstrates certain levels of safety and efficacy, it receives authorization to move to the next stage. Clinical trials measure efficacy, the reduction of the disease in those who have been vaccinated. The clinical trials you hear most about are those in phase 3, the large-scale clinical trials. In one of these trials, participants receive either the experimental vaccine or a placebo. The efficacy of a vaccine is calculated based on the differences between those who receive the vaccine versus the placebo and whether they got the disease. In the US, there are currently 2 vaccines approved under emergency use authorization: Pfizer-BioNTech and Moderna. Johnson & Johnson submitted their EUA application earlier this month, and a decision is expected by the U.S. Food and Drug Administration in the coming days. An EUA, again, an emergency use authorization, provides for a thorough but still more expedited review process by the FDA, allowing a drug or a vaccine to reach the public more quickly. After receiving an EUA, a manufacturer will continue to collect data. Once they determine there is enough additional information for the FDA, a manufacturer can apply for a full licensure. They work closely with the FDA on this process. Full approval is known as a Biologics License Application, also called a BLA. Pfizer has indicated that they plan to request a BLA, full licensure, in April. There are additional vaccines in the pipeline. Vaccines in phase 3 large-scale clinical trials in the United States include AstraZeneca, Janssen, and Novavax. Typically, the development of a vaccine can take place over the period of 5 to 10 years and sometimes longer with no guarantee of success. The development of the COVID vaccine has occurred at an accelerated pace when we look at typical vaccine development. This is the result of tremendous effort of our scientific community and investment by public and private entities around the world, resulting in a number of vaccines with high efficacy rates. The challenge now is supply. There are efforts underway being led by the federal government to help manufacturers produce more vaccines and increase the supply. The first vaccines were delivered in the United States on December 14, 2020. Since then, more than 42 million people have received 1 or 2 doses of the vaccine in the United States. We have a population of over 330 million people. 267 million adults are eligible for the vaccines. This means 12% of our population is partially vaccinated, and 5% of people in the U.S. are fully vaccinated. You can see how distribution has been increasing over these past 2 months. Our goal is to achieve herd immunity. The pace of production must continue to accelerate in order to distribute more vaccines around the country to ensure we can begin to achieve levels necessary for herd immunity. We're focused here on our national context. It is important as we look ahead to achieving herd immunity that we remember the global dimensions of this pandemic and the importance of a global vaccination strategy as a way of managing the overall pandemic and as members of a shared global community. Global leaders, Pope Francis, the World Health Organization, and Director General Dr. Tedros, United Nations Secretary General Antonio Guterres, have all encouraged a global strategy for equitable vaccine distribution. There's a quote from Pope Francis that captures this important dynamic. What is at stake in ensuring people around the world receive the vaccine? And I quote, "Today, in this time of darkness and uncertainty regarding the pandemic, various lights of hope appear, such as the discovery of vaccines. But for these lights to illuminate and bring hope to all, they need to be available to all. We cannot allow the various forms of nationalism closed in on themselves to prevent us from living as the truly human family that we are. Nor can we allow the virus of radical individualism to get the better of us and make us indifferent to the suffering of other brothers and sisters. We need to ask everyone, government leaders, businesses, international organizations, to foster cooperation and not competition, and to seek a solution for everyone. Vaccines for all, especially for the most vulnerable of all regions of the planet." Close quote. For Georgetown, our community is located across 3 jurisdictions: the District of Columbia, Maryland, and Virginia. The federal government determines the amount of the vaccine each state receives. Once DC, Maryland, and Virginia receive vaccine doses, they each have their own vaccine distribution process. This is a challenge we have to wrestle with at Georgetown. We have almost 9,000 people in our workforce spread across the region. We have students on our campus and in our local neighborhoods. We are at the intersection of 3 jurisdictions. A resident living in Maryland experiences a different vaccine process compared with those living in DC and Virginia, despite all being members of our Georgetown community. Many of our clinical faculty, individuals over 65, and our medical and nursing students working in clinical settings have received vaccinations. And since mid-January, more than 150 of our medical and nursing students have volunteered through MedStar Health to administer vaccines. I'll speak to each location in turn, DC, Maryland, and Virginia, and provide key resources for further information in each jurisdiction. DC is in the 1B phase of its vaccine distribution. This is the list of those currently approved for the vaccine. Starting on March 1st, DC will enter phase 1C, which extends vaccination to those 16 to 64 with certain medical conditions. We have been providing periodic updates to our community on the vaccine processes in our region. And this week, we will be communicating about these additional updates from the District of Columbia, which may impact some of our students, faculty, and staff. As we move to look to Maryland and Virginia, remember each state has its own framework and its own process for managing vaccination. The phases don't correspond to one another in a direct way. Maryland is in phase 1C, focused on individuals 65 and older and in essential services. Virginia is in phase 1B. I mentioned a moment ago that roughly 12% of the United States has been at least partially vaccinated. To give you a sense of how far we have left to go here in Maryland, DC, and Virginia, a similar number, roughly 11 to 12% of the population, has been vaccinated. Among our nation's highest priorities must be the fast and equitable distribution of the vaccine across our states, territories, and in tribal communities. There is concern as we look at vaccination efforts that some of the communities hardest hit by the pandemic, our Black, Brown, and Indigenous communities, are not being vaccinated as quickly as predominantly white communities, where there have been fewer cases of COVID-19. I'll close with a few emerging questions that we'll return to in future presentations. In previous conversations, we've discussed the emergence of new COVID-19 variants, which are more transmissible and possibly more deadly. We need to understand how the vaccines perform against these new variants that are now circulating in the United States. We also need to understand what modifications we need to make to our public health guidelines as we grapple with these variants and higher rates of vaccination. And finally, we need to start to envision our expectations about a post-pandemic context. What will a return to normal life look like? And what new or different aspects of life might we expect? These are some of the ideas we'll explore together in future conversations. I look forward to being with you all again next week. Take care of yourselves and take care of everyone around you. For every Hoya, everywhere.